Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about something called reactive arthritis. And remember, we talked about the kind of 4 key seronegative spondyloarthritis conditions I want you to know are easily remembered with a memory aid pair. And so we have the P for psoriatic arthritis, ankylosing spondylitis, IBD-associated spondyloarthritis, and now we're dealing with the R for reactive arthritis. So reactive arthritis is in general a post-infectious autoimmune condition. What do I mean by that? That means a post-infection. An infection occurs, such as a bacterial infection in the body, and afterwards we see these symptoms. We see this inflammatory condition in the body. It's a reaction to a previous infection. These are classically infections in the GI system or the urinary tract. But again, it helps us remember the name, right? Reactive arthritis. What's it reacting to? It's reacting to a previous infection. So if we jump in here with the pathophysiology, this is once again a seronegative spondyloarthritis. Seronegative meaning that it does not have the IgM rheumatoid factor. It's negative. The serum lab is negative for the rheumatoid factor. And in this condition, again, it's a post-infectious reaction. We get increased immune response following the infection, leads to T cell and macrophage recruitment, damage to the joint, synovium, conjunctiva, urethra, and cutaneous infiltration. So again, just to summarize that in real simple terms, we have a infection that occurs. We then get a immune response afterwards, leading to elevated inflammatory reactions in the body, T cells, macrophages, all of the cells we expect to see in an inflammatory reaction. And this is going to destroy tissue. Again, it's kind of a theme here with these seronegative spondyloarthritis. Inflammation occurs, or unnecessary, unwarranted inflammation occurs in the body. This ultimately leads to destruction of the tissue. So a lot of times this is good, healthy tissue, and that's where we have some of these findings, right? We want the immune response to work in the body when we have bad things going on, right? We have an infection, we want to attack it. But when it gets out of control or it starts attacking our own tissues, that's when we get some of this damage that we're going to talk about here. So when we think about our clinical presentation, this is often going to present with asymmetric migratory oligoarthritis, typically in the lower extremities. Again, we've kind of talked about these before, but it's migratory, right? So it goes from one joint to the next. It might be their left knee one day, and then next week it's the right hip. It's an oligoarthritis, so usually more than one joint is affected. And in this particular condition, they're usually lower extremity joints. The classic triad they like you to know, and I'll put a star by this, is these patients will have conjunctivitis or inflammation of the conjunctiva, urethritis, and arthritis. And the memory aid that we use for this is right here. This can't see, which is for the conjunctivitis, can't pee for the urethritis, right? Inflammation of the urethra, and can't bend my knee for the arthritis. So again, all together, can't see, can't pee, can't bend my knee is a very helpful memory aid we can use to remember the classic triad or reactive arthritis. And again, this is important because as you're reading question stems, right, you're kind of maybe highlighting either literally or in your brain, what are some things that are standing out to you? What are some physical exam findings? What are some clinical presentations the exam writers are giving you? If you come up with this triad, they're often pointing you in the direction of reactive arthritis. So be mindful of this pathology if you see these three things in conjunction. Now, again, I always like to say that doesn't mean the question will always have these three things, right? They might give you 2 out of 3. They don't want to always give you the answer super easy, super directly. But keep in mind, have these kind of circulating in your brain if you start to see some of these exam findings or these clinical presentations showing up in a question stem. Now, one pretty unique cutaneous manifestation I want you to keep in mind is this one right here called keratoderma blenneragicum. And this is seen in this image right here. And what we're seeing is excessive keratinization or excessive amounts of hyperpigmentation on the feet. And this is a very classic physical exam finding of reactive arthritis, also formerly called Reiter syndrome. Now, it's really important to also be mindful of the diagnostics here. And in general, this is going to be a clinical diagnosis, right? If a patient presents with these triads, there's not a specific image that we're going to get that's going to tell us, yes, this patient definitely has a condition or a specific lab. It really is the whole patient presentation. So when we think about what can cause reactive arthritis, we want to think about classic triggering infections. These include things like Campylobacter, chlamydia, C. diff, E. coli, Shigella, Salmonella, and some other ones as well. So if a patient comes in with urinary tract infection, and then a week later they present and they have some more of these arthritis conditions, well, this could be indicative of reactive arthritis. Now, also important to know, this is a seronegative spondyloarthritis, and we've previously talked about how these are associated with the HLA-B27 gene. This is also an inflammatory condition, so we're going to see increased inflammatory markers such as CRP and ESR. And again, it's a seronegative spondyloarthritis, so it's typically negative for rheumatoid factor and also negative for the anti-CCP antibodies. Now, when we think about the management for these conditions, it's important to advise patients that these are often self-limited, but they can take several months to resolve. But in the meantime, it's okay to actually treat the patient's symptoms. These can include things like non-steroidal anti-inflammatories, glucocorticoids, or potentially even DMARDs for chronic/severe disease. Now, exam writers also like you to know that you need to treat the underlying condition, right? If somebody has reactive arthritis, they might still have that underlying chlamydia, right? We talked about how that can be a very classic triggering infection, right? Somebody gets a urinary tract infection or they get an STD, a sexually transmitted disease. They get the chlamydia. Now they're having these signs of reactive arthritis. We need to treat the symptoms of the arthritis, but you also need to treat the underlying condition, and that might include the use of antibiotics. And so again, it's a very classic thing that they want you to know. They want you to pick the answer choice that treats both the underlying infection and the current symptoms the patient is having. Don't just give the anti-inflammatories if the patient likely has a sexually transmitted disease. Maybe they need further testing for that. Maybe they need some antibiotics as well. Additionally, it's also important to know that this has a high rate of recurrence. Patients who have this condition once are at a higher risk of having this condition again later on in their life. So potentially on a question stem, they might give you something along the lines of a 23-year-old female presents to the clinic with a chief complaint of left knee pain for the last week. The patient denies any other symptoms at this time, but they are sexually active with multiple partners. On physical exam, the left knee is mildly swollen without erythema or warmth. And on labs, the patient is noted to have an elevated ESR, in addition to a nucleic acid amplification test that is positive for chlamydia trachomatis. The question can then ask you which of the following is the best treatment option at this time. It'll give you a lot of different things, right? It might talk about ibuprofen, it might talk about doxycycline, it might talk about Tylenol or vancomycin. But the key here is that the question is asking you which does this patient need to be treated with. You need to treat all of their condition. So the best answer would be something that includes both an antibiotic and for symptom management like naproxen or another anti-inflammatory. Again, it's important that you get both of these in there. It could be doxycycline and naproxen as the best answer for this patient. You don't want to just treat the infection, and you don't want to just treat the symptoms if you suspect the patient has reactive arthritis. So just a quick summary to wrap up this video. We're talking about reactive arthritis here. This is a seronegative spondyloarthritis. Again, it's negative for the rheumatoid factor. This is typically due to an infection that leads to an increased immune response in the body, increased activation of macrophages and T cells, and ultimately damage or destruction of different areas in the body. The classic triad this will present with is the can't see, can't pee, can't bend my knee. That's the conjunctivitis, urethritis, and arthritis. And be on the lookout for this pretty unique physical exam finding as well. In general, this is a clinical diagnosis, and it's typically due to a variety of different infections that can actually trigger this pathogenesis or pathway of reactive arthritis occurring. When it comes to management here, we want to treat both the symptoms, such as the joint pain, in addition to any underlying infection with antibiotics. Two key things important to know here, that this is typically a self-limited thing. This will take time. However, antibiotics can help treat that underlying infection. And patients who have this have a high rate of recurrence. So that is to say, if a patient has it once, they're more likely to have it again later on in the future as well.